Well, we have hot news now from the European Multidisciplinary Cancer Conference. With me is Michael Link, President of ASCO from Stanford University. Michael, it's great to have you with us, especially as you're involved with this session on improving quality of delivered care. Now, your particular area, of course, is pediatrics, but what is it that's important about this whole issue of cooperating, especially between ECHO and ASCO?
Well, we have a tradition of learning from each other. So ASCO and ECHO are really multinational organizations, and we need to really improve the quality of cancer care for our patients throughout the world. So here we're learning tricks from what the Europeans have piloted and tried, and we have our own things that we are trying to improve quality of patient care. So this is an opportunity for us to exchange those ideas and see if we can help each other out.
And the session refers to tools and guidelines. What sort of things does that mean?
Well, ASCO has a program called COPI, or the Quality Oncology Practice Initiative. And this is a way of seeing if the processes that are involved in patient care are lived up to in practice. So we have guidelines for what should happen to a patient, and practices can score themselves against each other and see how well they're doing compared to what our expectations are. And then we hope that in areas where they fall short, that they would have improvement processes in place to improve the delivery of the care.
Now, Dr. Blaney, also from Stanford, incidentally, is delivering this talk. But what can doctors actually do, busy cancer doctors, to use COPI? How does it work, in fact?
Well, what it allows them to do, and this is sort of a first phase of trying to improve cancer care, is to really document how they're caring for patients. And I believe that Dr. Blaney talked about a program that was instituted when he was at the University of Michigan, where they thought of a process of trying to give the best end-of-life care, meaning that patients weren't getting chemotherapy close to the end of life. And they found out that they didn't do that well, and they had their own explanations for why, mainly that they were taking care of patients that were sicker, patients who came to the University of Michigan specifically for experimental therapies, and yet they found they were really not living up to the national standard in this one area. And so with a quality improvement program, they actually then raised themselves to a level which was more acceptable for them. So this is a demonstration of how you can actually grade yourself, see where areas where you're falling short, and then develop processes to improve things.
Of course, we have made huge progress in treating childhood cancers. So how much scope is there for improving this thing called quality?
Well, we think that what we've done in pediatric cancer is really a poster child for quality of care. How did we do this? Well, we have a tradition of multidisciplinary care. We have a tradition of cooperating with one another. We have a tradition of putting patients on clinical trials where the actual care is specified, the regimens are specified, and it's a continuing improving process where we do a study, we improve that one therapy may be better than another or less toxic than another, and that becomes the new standard of care for the next treatments. So this is a model, and as you know, we've over the last 30 years have improved the outcome for children so that we cure almost 80% of all children with cancer. But these are the steps that it takes, and we hope that by putting these kind of tools in place, protocolized therapy, guidelines, cooperation, international cooperation, that we can improve the quality of delivered care for all cancer patients in the world.
And can you tell me what Dr. Schulman from Boston is doing about IT and how this helps too?
So one of the keys to trying to do this is the ability to extract information. So we need feedback both from patients and from physicians to see what has happened to patients in the course of their care, how they were staged, what their diagnosis was, what care they received, and what the outcome was. And of course, this is an enormous task if this information has to be sent manually or typed into or entered into computer programs. So the goal would be to actually extract this information from medical records, electronic medical records, which are becoming the norm, anonymizing the patient data so we can see in aggregate what happens to groups of patients with a specific cancer diagnosis, how they're managed, and what the best outcomes are. So this requires an IT infrastructure which allows us to get this information into a central database from the electronic medical records.
It also requires an IT infrastructure that the doctors find enjoyable and relatively time efficient to use, doesn't it?
Absolutely. Well, as you know, in the United States, we have incentives to get electronic medical records into offices as well as into major hospitals. And so the idea is, how will these communicate with one another? Can we extract information from this, and can we keep it so that this is not proprietary, the codes that underpin these? And that will be a major step forward in the next few years to try to really understand what's happening to cancer patients.
So what brief messages do you think cancer doctors should take home on this issue of quality?
Well, I think that progress will depend on really taking the newest knowledge, the latest knowledge, and getting it out into the community practices where patients are cared for. And so this will require interaction with the medical record. We hope that there will be opportunities where the medical record can actually help the physician choose the therapy, remind a physician that a patient is on a specific medication which may interfere with a specific cancer therapy, and so allow him to make an intelligent dose adjustment or choose an alternative therapy. These are the kinds of things which are already in place in some areas and which are an obvious opportunity to improve cancer care really throughout the world.
Now, your own subject, pediatric cancer, is certainly being aired here in Stockholm, and I know that choosing the patient and risk stratifying is very important. What have you got to say about this? How can it be improved? Because we don't want to have second malignancies somewhere down the line and other morbidity. What's the situation right now?
Well, here's another opportunity where we can learn from our children. So what we have done in pediatric oncology is we've had the fortune of being able to now cure the majority of patients, and these are children who have an entire lifetime ahead of them in which we can see the side effects of the therapy, the price of cure, if you will. So it is our obligation to see what we can do, to see what components of that therapy were actually necessary, and to try to eliminate those aspects of therapy that are unnecessary, that only cause toxicity. So you will see that a recurrent theme in pediatric oncology is a focus on survivorship, on the quality of life after being cured of cancer, and then a feedback on our treatments that worked 10 and 15 and 20 years ago. What have been the adverse effects of that therapy, and what components of that therapy can be eliminated without compromising on the cure rate, but improving the quality of life of the survivors? That's our goal.
How do you advise doctors to take all of this on board? Because they do have a sick child to deal with initially.
Well, we've designed protocols. We hope that patients help us answer these questions, as can we eliminate some of these toxicities of therapies? And so we sometimes, in a very curable malignancy like non-Hodgkin's lymphoma and Hodgkin's disease, for example, where we know we can cure the majority of children, we take those children that have the highest chance of being cured, and we try to look at those components in a randomized trial where if we eliminate what we consider the most toxic components, can we achieve the same cure rate with less toxicity? This has been a theme that's been going on for 10 to 15 years in pediatric cancer, and it's worked in Wilms tumor, in lymphomas, and also in the treatment of leukemia.
But how much support can you give to individual doctors? Because it could be a brave decision to withhold certain levels of treatment, couldn't it?
Well, we would only do this in the context of a clinical trial. We have to give what is evidence-based and tried and true to a patient before us. But if the patient is willing to participate in a trial where we can learn something, and that patient has the potential to benefit from the reduction in treatment, that is the kind of collaboration that we have had with our patients for the last 20 to 30 years to help us improve not only the cure rate, but also the quality of life for the survivors.
But there is scope, you believe?
I believe that we have many more questions that need to be answered. We're curing the majority of children, but we have children with certain diseases which are more difficult to cure, and we need more intensive and better therapies for them. And then we have the group of children where we can cure them in the majority of cases, but we still have adverse effects that we would like to eliminate from treatment if we can.
Let me ask you about molecularly directed therapies, because these have certainly made inroads in adult oncology. In the pediatric setting, how much promise is there for using some of these directed drugs?
Well, we think that where we've had the opportunity, we already have a couple of examples where we have really changed the field. One is a particularly difficult to treat leukemia, Philadelphia chromosome positive acute lymphoblastic leukemia. We've incorporated imatinib, and we already can see a change in the outcome of these children for the better. We are already improving the outcome for a very difficult to treat leukemia. And another rare leukemia, acute promyelocytic leukemia, we've learned from our adult colleagues the use of all-trans retinoic acid and arsenic, which has made the leukemia much easier to treat and has improved the cure rate. So there's two examples, and we have a number of potential targets which are available and for which there are now medicines. Crizotinib has a lot of promise, recently approved for the treatment of subsets of adults with lung cancer. Turns out that that same target is present in a anaplastic large cell lymphoma, a kind of non-Hodgkin's lymphoma. In fact, the ALK gene, which it targets, was in fact cloned from a pediatric patient at St. Jude. So this is an area where we have really exciting molecules which will hopefully add to the armamentarium for childhood cancer as well.
You've got anti-CD30 therapy too.
Oh yes, of course, there the diseases are very similar to adults. In Hodgkin's disease and anaplastic large cell lymphoma, there's now a toxin-conjugated monoclonal antibody which has great promise to treat patients who develop recurrent disease, and hopefully will be incorporated into the frontline therapies to improve the outcome.
Could you give me a brief, broad brush of how things are with childhood cancers, because there was enormous success early on, of course. How much progress have we made, and how many of them do we cure?
So, during the course of my career, although not necessarily because of the course of my career over the past 30 years, we've raised the cure rate from approximately 35% to 80% overall. In childhood acute lymphoblastic leukemia, which is the most common childhood cancer, we cure close to 90%. Again, understanding the heterogeneity of the disease, incorporating new therapies. But for many of these diseases, we're using the drugs that were available 20, 30 years ago, but we just know how to use them better. So great progress has been made, and as I said, we're now focused on improving the quality of life. But we have hit a little bit of a brick wall for ourselves as well. The cancer death rate in childhood has sort of plateaued. We've made many of the early, or we've picked the low-hanging fruit, if you will, and now we are desperately in need of new paradigms, including these new targeted therapies to help us.
Can I ask you about a difficult area, adolescence with cancer, because again, it's often being said that you can learn from the childhood situation. Any progress there?
Well, we've made progress in the treatment of adolescents as well, but they have been a difficult group to treat for a variety of reasons. Any parent knows who's ever had an adolescent child can understand the problems of compliance, the problems of willingness to go through therapy, but also it's the basic biology of the cancers that they get are less favorable than our younger children. But we know that with proper therapy, especially, for example, in acute lymphoblastic leukemia, these are children or adolescents that have a higher risk form of the leukemia, and we now made great progress there as well, although we still have a ways to go.
And the modalities for treating them would
very
be
similar,
the same?
just more intensive treatments, better use of the drugs that are available, and the promise of some new agents, like imatinib in Philadelphia chromosome-positive ALL, which is a disease of adolescents and young adults.
Finally, I would like to ask you what you make of your job with ASCO now, and the fact that ASCO has had the vision to appoint an expert in pediatric oncology. I'm struggling to remember a prior one.
No, I'm the first pediatric oncologist who has had the privilege of leading ASCO. It is a wonderful organization, and I think this tells you that our cancer organizations are now multidisciplinary. We realize that it takes a village. It takes oncologists and radiotherapists, surgeons, nurses, social workers, everybody, and so ASCO, like the European organizations, are a conglomerate of all the professionals who have a hand in taking care of patients with cancer. It's a great privilege. It's a lot of work and a lot of travel, which I hadn't anticipated. My wife didn't anticipate it either, but she's accompanying me on some of these trips. So it's a wonderful opportunity.
And the benefits of ASCO cross-fertilizing with European organizations like this multidisciplinary Congress here in Stockholm, what do you think is that benefit?
Well, we learn from each other, and the problems that we face are similar. We have similar diseases, and I think one of the interests of the European organizations as well as ASCO is that they are international, and we have to be very cognizant of the experience of cancer patients in the less well-developed world, where some of the therapies that we're developing now are just unaffordable for their healthcare system. So we still have to develop therapies that will work and be available for the developing world as well. And I'm proud to say that the European pediatric societies have been very good about disseminating therapies in the developing world as well. So this is on target for all of the European and American Society of Clinical Oncology as well.
Dr. Michael Link, it's great to hear from you here in Stockholm at the European Multidisciplinary Cancer Conference. Thank you very much for bringing us that hot news from the conference.
It's a pleasure to be here. Thank you.